presentation will be given by myself on a trial we're doing on comparing 23 gauge and 27 gauge vitrectomy. I work as a consultant for many companies. I'm also getting a grant from D.O.R.C to be able to do this academic trial. Now, when vitrectomy started in the 80s, the instruments were much larger than what we're using now. It was 20 or even 19 gauge, and during the years we have evolved into much smaller instruments, and 27 gauge now being the smallest size available. Industry has worked hard to improve the design of the instruments. The forceps that we use now in 27 gauge resemble a lot, for example, than the 23 gauge version. Also, the alloy that's being used, or the steel, is much stiffer than it used to be, and this is a comparison between an old and a newer design of hand gripping forceps, and you see how the new stainless steel is much sturdier and bends a lot less than the old one. Also, instruments are being designed with a reinforced instrument base, which helps again against the bending of the instruments. This is, for example, a light fiber built in this way. And finally, in order to optimize the inner lumen of these instruments, new designs were created, such as this 27 gauge backflush instrument, which allows you even to do passive backflush in 27 gauge. Now, we all have the impression that 27 gauge surgery is better with respect to outcome, that the eyes look better or less inflamed. But the problem is that there's only circumstantial evidence. We don't have any real scientific data to back up this suggestion. And that's why we're doing now a single center study in my university. And it's a pilot study where we'll include 50 patients. And I have two gauges available in my hospital, 27 gauge and 23 gauge, and we will do a comparison trial in between. I'm showing you today an interim analysis when half of the patients were included, 25 patients. I'm only including patients that undergo pars plana vitrectomy for floaters or for macular surgery, limiting it to VMT and puckers. Why is that? Because this is, I think, the most standardized vitrectomy indication, and we're not including macular holes because I'll only want to include patients where I do not use a tamponade, as the use of a tamponade may be an influencing factor of the amount of inflammation we measure into the anterior chamber. We prospectively randomized patients in 23 gauge and 27 gauge, and the question here in the study is, what's better? It's better to use the smallest instruments available, 27 gauge, which on the other hand will make the surgery a little longer because the fluidics are a little slower, or is it better to make the incisions less as tiny, making it a little bit larger, but on the other hand have a larger inner size of the instruments, which may speed up the surgery, make the surgery shorter, and this again could lead to less inflammation. So we don't know which of these is the most important, and that's why we're doing the trial. And I'm giving the patient the explanation in the same way, that we don't know yet which of two will be the best, and that's why we're doing the trial. Now, what could potentially influence the outcome of the trial, which is the post-op appearance of the eye? First of all, the combination with phaco surgery. In this trial, I'm including both vitrectomy-only patients and phaco-vitrectomy patients. And probably there will be a difference between groups, but for this analysis I'm showing you today, I'm not separating them up. I'm just separating the patients between 27 and 23. Otherwise, we would end up with patient groups of 3-4 patients, which of course is too few to do a proper analysis. Probably the number of coagulates also matters, that's why we're recording them. Maybe the anesthesia type matters, the age, the gender of the patient. The medication, of course, will also matter, and that's why we're giving exactly the same post-op medication in both study arms, and we also make note of any other concomitant medication that the patient may be using, and of course ILM peeling is also noted if done. This is a baseline analysis, so it looks at the baseline data in both study groups, and it's clear that the p-values are that high, which indicates that there is a good distribution among the baseline groups, that we have the same type of patients included in the 23 gauge arm and in the 27 gauge arm of the study. So let's look at the study outcomes that we're observing. Again, I explained that we are not separating between vitrectomy and phaco-vitrectomy. One of the outcomes is surgical time. What I'm measuring here is the time between the start of the core vitrectomy and the end of the core vitrectomy. A second parameter is what I need to do to close the eye. And we grade it in different levels. Grade 1 is a spontaneous closure. You take out the cannulas and the eye closes. 2 is that we need to massage the sclerotomy. If massaging doesn't work, we need to inject an air bubble. If that doesn't still seal the eye, we may suture the sclerotomies, which is the 4th level of closing of the eye. We give the patient a questionnaire and we ask about postoperative pain. A typical pain scale from 0 to 9. We ask the patient, did you wake up in the first week because of pain, and did you need to use ointment, which is mainly the case if the eye was sutured. Then we have 4 photographs of eyes that are not or completely bloodshed, and we take at day 1 an external photo of the eye with a smartphone, like a selfie but very close up, and we grade the amount of reddishness according to these standardized pictures. And we have the advantage of owning a flare meter in our department, and we do a flare measurement of the anterior chamber the day after the surgery, both photographing the operated eye and the non-operated eye. This gives you a number which is of course ideal to do this kind of evaluations. This shows you the interim analysis of the study of 25 patients. When we look first at surgical time, there was a significant difference that 23 gauge surgery takes 90 seconds less than 27 gauge surgery, which if you look at the whole duration of the surgery, I think is very well acceptable. The second significant parameter was the action to close the sclerotomies. We found that, not surprising of course, 27 gauge closed more easily significantly than 23 gauge, only in 25 patients. And the other parameters, there was a trend. Pain and discomfort was the same between both study groups, but both the reddishness of the eye, the visual acuity on day 1, and the flare meter showed a clear trend towards being better in 27 gauge, and I hope by the end of the trial, when we have included all patients, that we will reach significancy also in these study parameters. So, to conclude my presentation, the study groups in this trial were well balanced with respect to the surgical indication and the surgical technique. 27 gauge core vitrectomy takes only 90 seconds more than 23 gauge, which for me is perfectly acceptable. That wound closure is significantly easier in 27 gauge compared to 23 gauge. And when we have an independent grader look at the reddishness of the eye and the flare, that there's also a trend in the advantage of 27 gauge. Again, vitrectomy with phaco and with non-phaco was not separated because of the 2 small sample sizes, and we'll definitely do that in the final analysis. I'm also personally very curious to see how much additional inflammation a phaco causes. When you compare the patients that will only have had vitrectomy and we do a flare metering in the phaco-vitrectomy eyes, we will be able to see how much additional inflammation will be caused by the phaco. And of course, it's only a single center study comparing results from only one surgeon in a small patient group. So in order to get a more definite answer, I believe we should consider to do a multi-center trial as well. Thank you for your attention.
Thank you, Peter. Actually, that added a lot to the presentation in explaining the fluidics that we might speak about in a minute. Well, ever since 27 gauge was introduced more than 8 years ago, and we have Dr. Oshima here with us, which was one of the developers of this technique. I had some questions in mind once I tried to do 27 gauge or using 27 gauge technology. The Fluidics, it's one of the things that comes in our mind. Okay, the tip is small. Is it going to take much time to do a vitrectomy compared if I already have a 25 or a 23 gauge setup? PVD, can I do PVD in hard cases with a 27 gauge probe? The light problems, of course, it seems a little bit dim inside the eye if you compare the light pipes, and I'll speak about how the innovation helped to improve that, as well as instrument stiffness. Stiffness of the instruments, there was different stainless steel or different materials that would be used a long time ago compared to what we're using now. So these are main things that I think that were unmet needs when you're trying to do a 27 gauge platform. Well, let's speak a little bit about Fluidics. Peter very nicely showed that it only takes 90 seconds more, but there are two things that shared in this. First, the introduction of the TDC, which is the two-dimensional cutting probe. It keeps the opening nearly open most of the time, so the flow is not affected by the small 27 gauge. When you combine that with the vacuum flow on the machine, the Fluidics, you have good flow through the machine and at the same time good control when the port designed to grasp tissue and avoid damaging the retina. So you can have really good flow inside the eye, and that was nicely shown in Peter's study when he compared the Fluidics between both. There's not much affection that happens. Another point that comes to me is once you create a PVD, how do you grasp the PVD, especially to create it with a 27 gauge? It's easy maybe for adults, but what about pediatric cases? So I'm showing you here very tight adherent hyaloid, and you still with the 27 gauge with the new control, if you even go to 500 or 600 mils of vacuum, you can detach the hyaloid even in pediatric cases that have difficult PVD creation while you're using this platform. So I think that the limitation of flow or creating PVD or managing the vitreous is now much improved by the technology that we have on the probes as well as the machines. What about light? It's a very important point, because in earlier version, when we used to have light inside the I-25 gauge, you get this picture. If you compare it to the new modification that we have on the machine, it improved maybe by 50% if you compare both light fibers. Why did this happen? Because there is a new light module on the machine that increases the light significantly, also increase in the thickness of the light pipe inside the fiber inside the light pipe. This actually adds more 65% of more light, so overall you get a 50% more improvement if you compare the same setting that you're using at 80% on both the older version and the new version. On the machine you get much improved light inside the eye. Well, this is the classic, the older module. Of course, if you're using the microscope light, it's good. When you use the older 27 gauge, it's good, and you can get the job done even with this amount of light. Especially now when we have also digital microscopes, it even improves this illumination. But even on the older light modules, you can see that you have good illumination. But the contrast inside the eye between the tissues was not that good, especially when you have dim or when you compare it to doing a 23 gauge. This is the older module. But let's take a look what happened in improvements of the light module. This is with the newer light machine or the newer light fiber and the machine itself. You have very good contrast inside the eye. The contrast is very good, and you can see very brightly inside, and even you can decrease the light. You don't need to have a high cranking light anymore. You can even use without the digital microscopes maybe up to 60%, or when we use digital microscopes you can even go down to 30% of the light that you need using a 27 gauge fiber. What about instrument stiffness? Peter very nicely showed that there is a modification that happened. The materials that we're using, it made it much stiffer, which adds to, there is no bending of these instruments inside the eye as it used to be before. This is one of the new forceps that is introduced by D.O.R.C, which I like quite, which is the ultra peel. See the thickness of the blades and the serrations. For tight or for stiff membranes, you can use the ultra peel. Grasping IOLs, dropped IOLs, this is also a very good forceps to use. So it really has a good force inside the eye. If you're grasping tough tissues or you're trying to dissect membranes, this is a good forceps to use. It's also reinforced here, and the material is much stiffer than it used to be before, which adds to our armamentarium in doing vitrectomy or doing membrane peeling. So in this patient here, I'm using the ultra peel with a new light source, and you can see that you can grasp the tissues that are very tightly adherent to the retinal surface without having shearing, and you grasp it all as once. Of course, the shearing forces depend upon the size of the grip and the instrument stiffness. So you can see that you can grasp a whole membrane just in one piece without having shredding. You can use that same forceps also, which is the ultra peel, to remove the ILM. Though it doesn't have the ideal tips for ILM peeling, and I'll I'll show you that in a minute, but still you can use that same forceps to remove epiretinal membranes and remove the ILM at the same time without having the shearing that happens inside the eye. Don't forget that these tips are usually less than 27 gauge, so you don't have much tissue grasp in it, so sometimes shearing does happen, but as you can see here, it didn't happen with that forceps. Using 27 platform, you can have good illumination, get a job done, and at the same time, at the end, you can just remove your cannulas and you have a very quiet eye like this that doesn't have much of inflammation on table or the first post-operative days. Another modification is another forceps here, which is the wide grip. I prefer this one more for ILM peeling because at the tip here, it's wider than the ultra peel. It doesn't have much serration, so it's mainly developed for removing ILM specifically or epiretinal membranes. It gives us a wider grip. Wider grip means you have more tissues inside the forceps, so you want to initiate a shear or initiate an ILM, you have a better grip that prevents having shredding inside the eye. So in this particular patient here, it has an epiretinal membrane, and you can see that I'm using the dual blue. It's a tough epiretinal membrane. I'm removing the membrane with the ILM all as one sheet. So it has a very good grip. This is the wide peel, the wide grip, not the ultra peel. And you can see the blades are wider compared to the ultra peel, which gives you a good grip of the tissues, ILM and epiretinal membranes all at once, and it has a good shearing force that you can even bypass problems when you have very tight adhesions over the retinal surface. So also this is a good option in our armamentarium. If you're doing 27 gauge, you can have a clean retinal surface like this by using more developed forceps. The good thing also is the opening that we have inside. I like to see the retina while I'm doing the shearing. I like to see that I'm not grasping retina when you try to re-grasp again. At all times, I use this opening inside the forceps to see the retina while I'm doing the shear to make sure that you're not grasping any retinal tissue when you start to initiate or you're doing the ILM peel inside. So these are good tricks and good things that we have in our armamentarium doing vitrectomies. We still don't have the scissor. We don't have a 27 gauge scissor. But theoretically, do we need a scissor most of the time? The answer is not as before. Maybe in some bimanual surgery. Some of the tricks that I use, of course, we don't have a good 27 gauge scissor, but I can use 27 gauge needles to initiate a cut in any membrane, then use the scissor to delaminate or remove it off the retinal surface. So though we don't have scissors, but you can use 27 gauge needle to start your dissection of epiretinal membranes, then continue with the cutter to remove it off the retinal surface. So when you compare all this stuff and summarize it in some of the cases, this is a pediatric Marfan retinal detachment. So it has a tight hyaloid. You can detach it with a 27 gauge cutter and do your vitrectomy. There's not too much time that is taken over comparing it to 23 gauge because with setting the machine correctly, you can create a PVD, do your vitrectomy, it doesn't take much time. What about the rest of armamentarium that we'll use? You have needles for injecting perfluorocarbon? The answer is yes. So in that part, it is answered. Doing laser, of course, we have very good lasers to complete our surgery. What about even silicone injection? Now with the new silicone injection, you can do silicone injection inside the eye, and it takes a little bit longer, I would say, than using 23 gauge, but at the end you have a good clean eye, quiet eye, doing most of the things that you need to do with larger gates and accomplish what you need to do. So I think with the new technologies that we had, it did add to our armamentarium, improving fluidics, light inside the eye, improving the instrument's performance and stiffness and design, added to our capabilities of using 27 gauge more and more, and resolving some of the unmet needs in the 27 gauge platform. Thank you.
Thank you for the chair. Hello, everybody. Thank you to give me the opportunity to present here a result of the comparative prospective study between the 27 gauge versus 25 gauge vitrectomy by the D.O.R.C machine for posterior segment disease. The evolution of the vitrectomy was lead a reduction of the diameter of the probe. It was obtained 45% from the 20 gauge to the 25 gauge in 2002. And today, with the 27 gauge, it's still 20% additional reduction. Evolution is always about rethinking our technique to go beyond the limits. Besides being less invasive when compared to the 25 or 23 gauge, the 27 gauge carry additional potential advantage. Think to the design of the vitrectomy probe. So we perform two prospective randomized studies to evaluate the 27 gauge versus the 25 gauge. a vitrectomy for the management of retinal detachment, and the vitrectomy for the management of posterior segment disease, mainly macular hole and epiretinal membrane. What is our opinion about the 27 gauge vitrectomy? Is the procedure time longer than the 25 gauge? Is the procedure with the 27 gauge as safe as the 25 gauge? Does the 27 gauge procedure allow for less suturing? So we're trying to answer at this question. Since January 2018, we performed a single-center prospective randomized interventional study of 528 consecutive patients with retinal disease. There is 2 surgeons. The machine EVA by D.O.R.C with 27 gauge probe vitrectomy TDC used versus 25 gauge standard probe. 5 different groups of disease. The primary retinal detachment with limited PVR, epiretinal membrane, macular hole, a combined surgery, cataract and epiretinal membrane, and other vitrectomy. So I present you here the management of the retinal detachment after the selection based on our criteria. So we randomized 38 patients with the retinal detachment. There is 17 in the 27 gauge TDC and 21 in the 25 gauge. The primary outcome were the retinal reapplication after first procedure and functional result. The secondary outcome were the surgical and vitrectomy duration and frequencies of the sclerotomy suture. All complications were also recorded. All patients were followed up at least 3 months postoperatively. The inclusion criteria was the primary retinal detachment with limited PVR, age more than 18 years, no pulmonary vitrectomy, no additional eye disease or trauma, and the flow control parameters was used in the 2 groups. The examination was at baseline, day 8 and 15, 1, 2, and 3 months after surgery. The visual acuity pre- and postoperatively was recorded, stature and lens and ocular tonus, fundus examination with macular stature, tear localization, and PVR gradation. The intraoperative evaluation was the time for installation, time for vitrectomy until the air exchange step, time for surgery, laser or cryo for the retinopexy requirement, decaline requirement. Did we observe a retinal hemorrhage corresponding to some small traction of the retina? Evaluation of number of sutures at the end of surgery. So this is some example of retinal detachment was treated in this study. I present you this case at the left with the video. So as you can see, is the same as the 25 gauge. This is a 27 gauge surgery, so you can put the plug very easy. The vitrectomy, the core vitrectomy was very fast and efficient, so you can cut the retinal break. And you can inject the decaline with the 27 gauge cannula, as is easier than the 25 gauge. You make the air exchange step, and after that you can do the laser or the cryotherapy. In this case we use the cryo, and then you remove the plug, and as you can see, it's not necessary to suture. The sclerotomy was said. What is the baseline characteristic? In the 2 groups we have the same result. We have more than 50% who have phakic eyes and less than 50% of patients who have a macular detachment. The main baseline visual acuity was similar. There is no difference, no significant difference between the 2 groups. What about success of retinal detachment surgery? That was very good. The success was 88% in the 27 gauge and 95% in the 25 gauge. There is no significant difference. What about visual acuity? The visual acuity improved in the 2 groups. The main improvement was between 5 or 6 log in the 27 gauge group and 7 log in the 25 gauge group. No difference in mean postoperative visual acuity between the 27 and the 25 gauge group. This is the most important result. In opposite about what we through, the time of procedure was similar in the two groups. There is no difference in mean time of surgery between the two groups. As you can see in this graph, the different time ETM was similar in the 27 or 25 gauge. What about suture and complication? We have more intraoperative retinal hemorrhage in the 25 gauge group, so is 80% in the 27 gauge, is half rate than the 25. And if you focus about the suture, so we have just 25% in the 27 gauge group versus 61%. In the 27 gauge is half rate than the 25 gauge. And if you focus about the patient who need more than 2 sutures, so you have 0 patient in the 27 gauge and 30% in the 25 gauge. Now I present you the result of the study of epiretinal membrane and macular hole. We have 463 patients randomized in this study. We have 184 patients in the macular and epiretinal membrane in the 27 gauge and 198% with the macular epiretinal membrane in the 25 gauge. The primary outcome and secondary outcome are the same as the next study. So the surgical technique for macular hole was 25 or 27 gauge 3-port vitrectomy was performed. Epiretinal membrane and ELM peeling using brilliant blue, fluid air exchange. Tamponade was SF6 at 25%. Face down positioning postoperatively during 5 days. Here is a video with the 27 gauge of macular hole. So the core vitrectomy was very fast. And in this case, I perform a epiretinal limited membrane flap with the 27 gauge forceps. Is efficient. Fluid air exchange and put the gas, and then you can put the gas and remove the plug, and the sclerotomy are said. What is the baseline characteristic of the patient of epiretinal membrane? We have the same characteristic in the two groups. We have 184 patients in the 27 gauge and 198% in the 25 gauge. When you look about the time of surgery or vitrectomy time, you can see it's similar. And when you look at the patient of the characteristic of the patient in the macular hole, we have 42 patients in the 27 gauge group and 38 in the 25, and it's the same result. So the surgery time, the vitrectomy time, or the peeling time was similar in the two groups. So the 27 gauge forceps are quite efficient than the 25. There is no difference between the 25 gauge and the 27 gauge group in terms of total duration of the procedure, but also installation, vitrectomy, and peeling. No difference between 25 or 27 gauge group in terms of total duration of the procedure, as you can see in this graph. A significant improvement of visual acuity at 1 month and 3 months in the both groups. No statistically significant difference between the two groups at 1 month or 3 months in epiretinal membrane group. Same in the macular hole group. There are the significant improvement of visual acuity at 1 and 3 months in the both group, and the difference was not significant. What about complication? When you look about the epiretinal membrane group, so you see a little bit more intraoperative hemorrhage. But what is interesting here, as same as the retinal detachment study, we say that the suture is 3.2% in the 27 gauge, is half rate than the 25 gauge. And if you look about the patient who need more than 2 sutures, is 0 in the 27 gauge. in the macular hole group, we have the same result about the suture, 4.8% in the 27 gauge and 10.5% in 25. It was with the 27 gauge half rate than the 25, and it be a little more intraoperative hemorrhage and intraoperative tear. So in the epiretinal membrane group, with the limited core vitrectomy, the incidence of retinopexy, tear, and small retinal hemorrhage was comparable between the two groups. In the macular hole group, with more complete vitrectomy and posterior detachment, we observed a reduction in occurrence of intraoperative complication in the 27 gauge with TDC probe. So the sclerotomy, the 27 gauge procedure, significantly reduced requirement of suture. Why go smaller? The advantage is faster functional recovery, less postoperative inflammation, more comfortable for the patient, reduction requirement for the suture. What is the limit? Efficiency of flow control and flow aspiration, flexibility of the instrument, duration of the surgery, anti-rest to the TDC probe. So, the current study shows that the 27 gauge and 25 gauge are equal effective for management posterior segment disease. There were no significant difference in postoperatively visual acuity, central macular thickness, macular occlusal rate, or retinal success. There was no significant difference between the 27 or 25 gauge group in terms of duration of vitrectomy or total duration of surgery. To go beyond the technique limit is the surgical balance between the efficiency and safety. In the efficiency, you have a flow aspiration, quality of cut of probe, duration of procedure, quality of the result, easy of implementation. The safety is the complication, tear, intra or postoperative, hypotony, inflammation, hemorrhage, or retinal detachment. So, the efficiency of TDC technology in 27 gauge has been demonstrated. Additional instruments will be needed to push the 27 gauge TDC into the future standard procedure. Neither directional laser probe, subretinal cannula. It will be possible in the future to use only the 27 gauge TDC probe for all surgical disease of the retina. So we answer about the question. What is our opinion about the 27 gauge? If the procedure time longer than 25, you can see no. There is no difference between the 27 or 25. If the procedure with the 27 gauge as safe as the 25 gauge, yes it is, and maybe safer. Does the 27 gauge procedure allow for less suturing? Yes. Half the suturing rate of the 25 gauge. Thank you for your attention.
Dear colleagues, good afternoon. I would like to thank the D.O.R.C company for giving me the opportunity to share with you my recent experience with a new shorter vitrectomy kit in 27G. I would like to give you a small introduction, explain to you the new features of this new shorter 27G vitrectomy kit. We'll have a small discussion about it. I'll share with you some of my experience and surgical videos, and I'll make a small conclusion. So, from the previous presentations, we see that 27G vitrectomy system is very efficient for all kinds of surgeries, and we thought that it was needed to adapt it for shorter or smaller eyes. And this new kit just got the CE mark in June this year. So what has been adapted? The trocar inserter, the trocar itself, the vitrectome, and the light probe. This is a video that is provided by D.O.R.C company about the new 27G vitrectomy kit. I don't know if we can have the sound. But you see the comparison here between the trocar inserter and the new trocar itself. It has been reinforced with a sandblasted shaft to improve the retention. This is a light probe that also is shorter, but the light output itself was increased by 65% and is 20% shorter. Also, the cutter is shorter. It's not only shorter, but you see the proximal shaft has been reinforced to improve the rigidity, and the rigidity is also increased just by the fact that the vitrectomy itself is shorter. So this is now a length comparison of the instruments. I think this is maybe relevant for your clinical practice. So the shaft of the trocar is now, in the shorter kit, is 3 millimeter. The trocar inserter is about 7.65 millimeter. The TTC cutter is 21 millimeter long, and the light fiber is 16 millimeter. So now my question is, it seems to be very logical to use a small gauge for small eyes, but is it really like this? Small eyes or short eye is not simply short. They have actually anatomical challenges and very specific features, like short eyes might present a more elastic sclera and a thicker conjunctiva. There is, of course, less space to work in the eye, and by the fact that the eye is smaller, you will have more eye rotation during the surgery because you have less space to work, and also it might be more difficult to insert your instruments in the trocar. So this is the one of the solutions that is provided by this ultra-short 27G vitrectomy kit. So for the elastic sclera and thicker conjunctiva, you have the shorter one-step trocar inserter with a sharp blade. Of course, there is less space to work in, so we need shorter instruments with an improved rigidity. And the eye rotation, the difficulty of it is improved by sandblasted trocars that improves the retention in the sclera. You also have improved rigidity of the instrument, so it's easier to get in and out of the trocar. Short eyes are also very challenging pathology sometimes, especially by the young patients. So often we have anterior-posterior traction, strong adhesion between the vitreous and the retina, and the procedure in those late-stage disease might be long. And how to address these challenges? To address the anterior-posterior traction, you can use actually the vitrectomy as a scissor, as Professor El Hayes just told us before. For the strong adhesion between the vitreous and the retina, we've seen that the cutter is very efficient. And there is an improved rigidity. And once again, the sandblasted trocars and the sandblasted infusion line will help for the retention of the trocars in the skeleton. So what are the settings I'm using? It's just the same as for the regular 27G vitrectomy system. Those are my parameters I use for core vitrectomy, and those one for the shaving. So in the first experience I have, I think it's very useful to use these short instruments in 27G, especially for the pathologies that are including anterior pole structural changes in the retina. The short trocars and vitrectomy avoid damage to the anterior displaced retina. And when you have an elastic sclera, and it is very easy to do the one-step insertion of your trocar, transconjunctivally. And when removing the trocar, there is an eye sclerectomy closure. Also, the rigidity of the short 27G cutter allows to remove fibrovascular tissue quite easily and dissect it from the retina. I also agree with Dr. Hellerai is that we actually don't really need a scissor because the cutter is doing the job very well. And we also have an improved light probe, and which gives us a good elimination for a 27G setting. Of course, the trocars are shorter, so when inserting it, you really have to be sure that you are going all through the corridor. So now I would like to illustrate this by some surgical videos, just illustrate some points. So here you see nicely the comparison between the regular 27G inserter and the trocar itself, and the shorter one. And in this very inflamed eye, you see that we can go transconjunctivally just to insert the trocar in a quite easy way. This is another example of inserting the trocar. I just put it gently because you see it is also an anterior pathology here, just to be sure not to damage the retina. And this is a very rare condition. It's a patient with incontinentia pigmented that is quite mimicking ROP. And you see that even the vitreous is very thick and very fibrotic. And here we can appreciate the rigidity of the short vitrectomy cutter. And you also can appreciate that we have a nice illumination. So here you can actually lift this fibrovascular tissue, lift it, and we are able to cut it with this vitrectomy and release the traction and go further to the dissection and reach the posterior pole. What I would like also to illustrate is the way we can use this ultra-short 27G vitrectomy kit for congenital cataract surgery. About, I think for 4 years now, I'm using the 27G vitrectomy system to perform congenital cataract surgery in a young population. Because one of the advantages is that you have minimal invasive incision of 0.4 millimeter. And now we have this shorter 27G cutter that allows for improved rigidity, but also efficiency. And we do a corneal approach, 3 incisions, and we can use the infusion line as an AC maintainer. The rexes can be performed by the DDC cutter in the shaving mode. The lens is removed with the DDC cutter also. And you can do the posterior rexes also with the cutter. So I would like to illustrate this by this video. This video has been edited, but it's in a real time. So you see that you can insert this trocar sandblasted through the cornea and place it like in. This infusion line will play the role of an AC maintainer. And with the vitrectomy, I'm performing now the anterior rexes. And you remove the lens and the cortex remnants easily. You can also appreciate here the rigidity of the vitrectomy that's allowing us for this maneuver. And so now I'm going to perform the posterior rexes with the vitrectomy in the shaving mode. And therefore, I dissect the anterior hyaloid with some viscoelastic. And so there is no vitreous coming in the anterior chamber. So as a conclusion, I would like to say that the short 27G vitrectomy kit offers us a wide range of technical possibilities, even in complex vitreoretinal surgery cases. It allows for minimally invasive surgery in shorter eyes and appears to be safe and efficient for vitrectomy and for congenital cataract surgery, to be confirmed, of course, by further study since it is a recent instrument. Thank you for your attention.
Nerinckx. I was wondering which eye size do you recommend to use this shorter vitrectomy kit?
I would recommend it for very short eyes, in eyes starting from 16, 17 millimeter of action length up to 21. I think 21 millimeter of action length is the limit.
Okay. Dr. Reyes, I was just wondering, when you showed nicely how you make the PVD in 27 gauge, what typical vacuum settings do you use?
Usually from 500 to 600.
500 to 600. Yeah, I see. Dr. Nerinckx, I also wrote down a question. I saw that the instrument cannula that you use is also shorter.
Yes.
And I wondered, did you see it more often than the standard kit because of retraction entering in the subchoroidal space and creating a choroidal?
Well, that of course this could be an issue, and I think in this with this shorter trocar blade and trocar, that it is mandatory to check indeed if you are if you pass through the choroid. But I didn't have a case.
Okay, Dr.
It did not happen.
Dr. Reyes also has a comment on that method?
Yeah, our concern is always the size of the lens compared to the size of the eye, and when you have anterior retinal dragging, if you use the classic 4 millimeter trocar cannula, you'll either be bumping the lens or trying to get it difficultly inside the eye. So I think a 3 millimeter was advantage. The drawback is, as you just mentioned now, is you have to make sure that it passed through the choroid and you're in the correct plane before opening the infusion cannula. But by time there is other indications that will evolve, like getting a retinal biopsy, or if you're doing a lensectomy, as just Fanny just showed, or even managing anterior cases with PHPV, because the stiffness adds to trying to use these 27 gauge instruments for removing the anterior PVR or membranes in the anterior segments. So there is more indications evolving with the smaller gauge kit.
I totally agree that this shorter 27G kits is really efficient for all these anterior pathologies.
Right. I saw in Dr. Elrij's videos that you mentioned the use of a digital 3D microscope. I just want to mention a practical tip. If you want to go for optimal safety, it is possible with the EVA anyway to turn the endolight into much more yellowish light, which is much safer, but of course is not as pleasant for us as a surgeon. But you can simply work with yellow light and do a new white balance on those digital systems, and then the inside of the eye will be completely illuminated by yellow light, but what you see in the screen are the standard colors. So you can work a lot safer in this mode without being disturbed as a surgeon.
That's an excellent tip, because I tried using that, and I think definitely you can control the illumination inside the eye just by using the digital microscope. And I think also adding the new settings, you can decrease even the light pipe on the 27 gauge. You don't need as much light as we used to do before if you add that to it.
With the microscope that just got in, the new Artivo, I'm lower than 10% of light now. It's amazing. Dr. Mazit, I saw in your videos that you always install the infusion cannula at 12 o'clock between your working sclerotomies, which is unusual. Most of us, I think, put it in the lower temporal quadrant. So why do you do that?
I answer is my way.
Okay, it's very nice.
I put the infusion at the top of the eye in most of cases. In some cases in the temporal, but most of.
And you don't bounce to the eyelid speculum when you put it at 12 o'clock, when you rotate the eye upwards?
No, I don't have any problem.
Okay.
Actually, placing this side, I'll ask you, Peter, do you still use chandeliers as you used to use before with the 27 gauge?
No, I used it because I didn't have enough light with the old probe, but now we have the new probe and the digital microscope, so then definitely I rarely use it nowadays. Also, I found that if you use a chandelier in 3D mode, that you somewhat decrease your depth of field perception. If you have a light in your hand coming from the side, it gives you an increased depth perception. So it actually decreases the quality of the image in contrast to what we had earlier. Dr. Nerinckx, you told us that when you use the shorter instrument kit, that you use the same vitrectomy machine settings as before. But I was just wondering, purely theoretically, a shorter instrument would mean less resistance. So I would expect to have a higher flow in the vitrectome, for example. Do you notice a difference?
No, especially for shaving, for example, I noticed no difference, and that's why I kept my parameters the same.
Okay. Actually, I was going to say something about the chandelier. Thank you for asking me this already. Purely a surgical question for all of you. Dr. Mazit showed us in one video that he used an inverted ILM flap. Now, I use it in macular holes, in large macular holes over 400 microns. I don't use it in intermediate or smaller macular holes. I was just wondering, for the three of you, in which indication do you use in macular holes an inverted flap? Go ahead first.
I use inverted flap, ILM flap for actually all macular holes independent from the size.
In most of cases, I perform a classic surgery with the ELM peeling, and in some cases, I agree with you with the bigger hole, larger than 16 microns. So I perform a macular hole, ELM flap. Or some case like that is a patient who can't take the position after the surgery, and so I make a flap.
Well, I reserve flaps to holes larger than 500, 600 microns, but most of the time, if you just remove the ILM in smaller or moderate size holes, 500 or less, usually can get them closed. And let's go back to the original trials, Kelly and Wendell, back 20 years ago, they weren't even removing the ILM, and they managed to close the holes by cleaning the retinal surface. So I think the issue about removing the ILM is increasing retinal elasticity, which you can close up to moderate holes. But when it comes to plugging or preventing fluid from coming into the holes, these are for larger holes, over 600 microns, then I use flaps.
Okay. When I saw the study of Dr. Mazit about his success after surgery, you also noted how frequently that you needed to place 2 or more sutures. And therefore I wanted to give you a practical tip. If you work 23 gauge, you can also order from D.O.R.C the hybrid pack. And the hybrid 23 gauge pack actually has 2 trocars 23 gauge, which are your working trocars, and has 1 trocar 27 gauge, which will be your infusion trocar. And that 27 gauge infusion incision will always close, and that reduces the need of having to install 3 sutures. It occasionally happens in 23 gauge that I need to put 1 or 2 sutures, but never 3, because one incision is always, the infusion incision is always 27 gauge. So you can order these kits from D.O.R.C if you want a hybrid kit. And one last question, we still have a few minutes left, except if there are questions from the audience, feel free to address us. I'm training a new fellow now, and he's now doing his first ILM peeling steps. And when I initiate an ILM peeling, I just take the forceps and I grasp the ILM and I peel it. But I remember when I started that we used to initiate the ILM with an instrument, a needle or whatever. And I just would like to ask you, how would you advise to a beginning surgeon how to initiate a nick, an opening in the ILM, without creating damage in the underlying neural retina? So maybe you can start with Fanny.
Yes, I think we have quite the same age, so there have been a lot of improvement also since that we were fellows, and I think with the forceps we have now, I would recommend to just initiate it directly with the forceps and lift a little bit the ILM and try to peel it without any adjuvant.
Okay. Dr. Mazit?
I started peeling with the forceps in the down position of the macula and near the viscer. I concentrate to don't have touch of the retina, so I just take the surface and I begin the peeling.
Well, it's easier to start the ILM with larger forceps if we were speaking about 23 or 25, but the challenge came when we were using 27 gauge, because usually the grasping area, you don't have much tissue to start initiating, but still you could do that. I liked always to be perpendicular on the retinal surface, to keep the angle of the tack not like this, but vertically, so you grasp tissue, and I pinch and peel and look before I start my ILM peeling. That's why I like the forceps that has an opening in the middle, so you can always see the amount of tissue or what you're grasping before you start doing the shearing. The shearing itself, I tell my fellows, around the arcades, and always grasp over the retinal surface. Don't pull towards the surgeon, then you get shearing or you get threading. But once you go over the retinal surface, you have a good flap to continue it all as one piece. Never grip again over the papillomacular bundle, so I start initiating around the arcades or temporally.
Thank you. I'm out of questions. If there's no questions from the audience, I would like to thank you all for your attention and see you next year.
Well done.